Welcome to the Michigan Cancer Consortium webinar on electronic cigarettes, vaping, and associated lung injury. Our presenters are Dr. Douglas Ehrenberg, Rita Seith, and Karen Brown. We hope you enjoy this presentation and the additional resources that are available on the Michigan Cancer Consortium website. We are delighted to have Dr. Douglas Ehrenberg from the University of Michigan join us. Dr. Ehrenberg's practices are focused on lung cancer, early detection, and tobacco cessation. He helps patients determine their lung cancer risk and has extensive experience in assessment and staging of people with pulmonary nodules and known or suspected lung cancer. He works intimately with the multidisciplinary lung cancer clinic team, including medical oncologists, radiation oncologists, thoracic surgeons, radiologists, and nuclear medicine specialists. Dr. Ehrenberg, thank you for taking the time to share your knowledge with the Michigan Cancer Consortium. We are looking forward to your presentation, and I'll turn it over to you now.
Okay, thank you. And I assume you can hear me still.
Absolutely.
All right, well, I'll get started here. I think, we're having this conversation in the middle of a pandemic, but before this outbreak of COVID-related lung disease, this topic of electronic cigarette and vaping associated lung injury was quite popular and quite relevant. And I think that we don't want to lose too much sight of this. And I was asked to talk about this a lot. And as I talk to other audiences and colleagues and other health systems about this, one of the things that I realize is that you really can't talk about this illness, this acute illness that results from the use of certain types of what we call e-liquids and inhaling them into your lungs. You cannot talk about this outside the context of a much larger epidemic, which has been going on for almost a century, and that is an epidemic of nicotine dependence. So part of the reason for this talk is to essentially put this into context. And so I'm going to spend a lot of time talking about nicotine dependence and why it's so very important to understand this if we're to understand this outbreak of e-cigarette associated lung disease. So this is an outline of what we're going to talk about. And in particular, people may wonder, why we're going to spend so much time on nicotine dependence. It's because really this is what worries me here, is that we have what appears to be an entire generation of people, like my teenage sons, for instance, who never would have considered smoking cigarettes and now taking up this new, what they think of as a hobby or a habit, but really is just, I think my fear is it's a new avenue towards promoting and adopting nicotine dependence. So with that in mind, I want to talk really about nicotine dependence from kind of a 20,000 foot view. I like to look at e-cigarettes kind of from this perspective. There is potentially a good related to these, and I think you get a lot of arguments about this depending on who you talk to. But if you want to start an argument amongst public health experts, talk about electronic cigarettes and whether there is any good that can come from them. So I like to talk about the good, the bad, and the ugly. And I think with this EVALI outbreak, there is an even uglier downside to this. So just a real brief and very rudimentary look at the way nicotine works in the brain, I think is worth it. And you need to understand this to understand where we are now with respect to e-cigarettes. Keep in mind that the tobacco industry generates $500 billion in yearly revenue based really on the chemistry of one molecule, that is nicotine. And you need to understand what nicotine does to your brain and how primitive and central the action of nicotine is in the brain related to all of the survival instincts that we have as mammals. And that may sound relatively general, but you cannot understand nicotine without understanding the dopaminergic reward pathway in the brain and what it does. And it is so very basic to our survival, such that anything that we do that promotes our survival involves the release of dopamine in this part of the brain called the ventral tegmental area, which triggers dopamine release which triggers neurons that release dopamine into a part of the brain called the nucleus accumbens. And without understanding any neuroanatomy whatsoever, what you need to understand is that these features of nicotine are absolutely fundamental to why it is so very addicting. So we're going to skip forward and I'm just going to show you in a graphic form. This is a paper with two figures that I borrowed. One is the figure on the top left, and if you look at the red up here, what you see is after about 1 or 2 cigarettes, that red starts to disappear. That is nicotine being, there's a tracer that is being displaced from the brain by nicotine, and after 3 cigarettes, the entire brain is saturated with nicotine. And that is a very short-term process, and what that does over the long term is shown here on the right, which is that the amount of green in the brain represents the number of nicotine receptors in the brain. And over time, even after you stop, nicotine receptors are expressed at a much higher rate in the brain than you would see in non-smokers, which is chemically why it makes it very, very difficult for smokers to stop. This is literally a visual depiction of why nicotine is so hard for smokers to give up. And if you wanted to devise a more potent way to kill people, you would really have a hard time coming up with it. If you were some sort of evil genius and wanted to come up with a way for people to die, you would have a hard time coming up with something that does it more efficiently than combustible tobacco. And this is just one picture showing a number of diseases which are highly morbid and highly fatal, and all of which are associated with the use of combustible tobacco. And this has taken place over the last century or so, to the point where nicotine is responsible for nearly 500,000 deaths annually in the United States and millions of deaths around the world. And just to take back another step farther, think again about all the things that allow a species to survive. So getting food or nutrition or reproduction, these are all things that depend on the presence of this active reward pathway in the brain. This is the pathway that nicotine exploits in your brain. And every time you put nicotine in your brain, this dopaminergic reward pathway is activated. These are very basic pathways in the brain. We share these with our most primitive ancestors and related animals. And here's just a bit of a way to look at this. Here's a squirrel that has escaped its predators on the right. And on the left, you have a squirrel that hasn't managed to escape its predators. If you were to look inside the brains of these squirrels, what you would find is that this squirrel here has very, very high levels of dopaminergic reward pathway being activated because it has managed to escape death. And this pathway is so fundamental to the survival of our species that every single drug of addiction works through activating this pathway. And the way to look at this is that if you are a smoker and you are trying to stop, your brain is actually experiencing the functional equivalent, the existential equivalent of a threat to your survival every time a smoker stops. And this is why when smokers stop using cigarettes and inhaling nicotine in their brains, they experience anxiety and other behavioral disturbances. These aren't signs of weakness. These are signs of the chemistry of nicotine and its effects on the brain. And every single drug of addiction that society deals with does the exact same thing. And each of these graphs just simply show the activation of the dopaminergic reward pathway throughout the brain as a result of ingestion of the drug. And they do so with varying degrees of effectiveness and varying rapidity, but all of them work through the same pathway. So the last thing I want to point out about cigarettes is that the tobacco industry has done a remarkable job of marketing to people such that they show themselves as providing a service to people who have made a choice to smoke. And really what they have done is they have maximally engineered the cigarette to provide and to maintain nicotine dependence. And so, for example, simple things like tiny little holes at the end of the filter here, which change how air flows through the cigarette and how air mixes with nicotine as it's released from burning tobacco, provides the tobacco inside the patient's lungs, or inside the smoker's lungs, I should say, at a very precise temperature. All of this is really remarkably engineered, and if it weren't so deadly, it might almost be admirable. to think of the degree to which engineering has gone into creating this modern cigarette. It's not just some old fella out in back rolling up tobacco from his yard and putting it in rolling papers. The tobacco itself is chemically modified in such a way that it increases what we call free-base nicotine by essentially mixing tobacco with toilet bowl cleaner. And this is something the tobacco industry started back in 1935. They added ammonia to tobacco, which made it cross the blood-brain barrier more rapidly. Now, why do I point this out? Well, most of us are old enough to have lived through recent crack cocaine epidemic, which took place in the 1980s and 1990s. And crack cocaine is simply regular cocaine to which toilet bowl cleaner had been added. And you might think that the cocaine dealers were the first ones to come up with this. Well, in fact, the nicotine dealers, if you will, the tobacco industry, came up with this chemistry and this chemical modification of their product back in the 1930s. And they were really the original crack dealers, if you will, and they've been very, very successful. And the only real way we've had to fight back has been through the recognition, through years and years and years of painstaking research, through public health officials and epidemiologists putting together evidence of the harmful effects of inhaled tobacco. And I like to point out this 1964 was the original Surgeon General's report pointing out the absolute toll taken by combustible tobacco on public health. And this was the 50-year anniversary in 2014 of the 1964 Surgeon General's report. And this report has been issued every few years since then as a way of essentially encapsulating all the scientific literature on the toll taken on human health by combustible tobacco. And more recently, the Surgeon General, just at the very beginning of this year, issued their Surgeon General report on smoking cessation. And we'll talk a little bit this out at the end because e-cigarettes are actually referred to in this report. And so I want to point out what happened in 1964. If you look at the peak of this graph, which shows the total number of cigarettes smoked per year in the US, it peaked in 1964. And as you can see, ever since then, there's been a steady decrease in the use of combustible tobacco. This graph ends in 2012, and I think this is really, if you will, there's some good news here. The problem is that it's very easy to look at this and come away with the mistaken impression that we are looking at the tobacco epidemic in our rearview mirrors, and that's just flat out not true. We're still looking forward to a century where public health experts predict there will be 1 billion predicted deaths in the 21st century as compared to 100 million in the 20th century. If we look back on the last century, 100 million people died from tobacco-related disease. That's more than every world war combined. And we think that's horrible, and we think we've done such a good job until we see what public health officials are predicting for the future. And part of the reason for this is that we've kind of harvested the low-hanging fruit. That is, we've gotten most people, most educated people, to stop smoking, and what is left are several populations that smoke at the highest rates, those who are very poor, the people who can least afford this, the least educated, and sadly enough, those with significant comorbid mental health problems. And so these are the populations that we as public health advocates have to really work with and reach and do our darndest to help them. And what's not on this is that largely where that death toll is going to take place is going to be in developing countries where very, very advanced and highly wealthy tobacco industries are exporting their product and exporting it and exploiting these populations in ways that would really turn your stomach if you really understood them. So that brings us to this. What is an e-cigarette? Well, these are battery-powered devices designed to deliver liquid solutions, typically with nicotine. Some of them use not a liquid solution, but a form of tobacco that is heated to a very precise temperature, such that nicotine is released, but it doesn't burn, so it's not combusted. Most of these use a low vapor point liquid, such as propylene glycol or other glycerol type liquids. And the most popular product on the market, which we'll learn about in a minute here, uses a salt-based nicotine reservoir. So there's not actually liquid involved, but it is a nicotine salt. And then you have what are called the heat not burn devices, HNB. Heat not burn is what I referred to earlier, is products with a very precisely controlled heating element that heats up specially processed tobacco, which is mixed with various solvents. It's typically a dry product that heats it to release the products without fully combusting it. And of course, the claim here is that because it's not fully combusted, that it is safer. And we'll talk about what safer means with respect to public health in a little while here. But electronic cigarettes were introduced into the world in the context of really a global epidemic of nicotine addiction. We hear the term global epidemic a lot now in the context of the coronavirus outbreak, and we're in the midst of it right now. But we have been in the midst of a global epidemic of nicotine addiction since the beginning of the 20th century, when nicotine went from something that was largely produced locally to something that was mass produced by machines and marketed and sold through really quite clever marketing strategies. Combustible tobacco, and I have to say this, if you take away nothing else from what I have to tell you, I will say this again and again: combustible tobacco is the enemy. Anything that can reduce the use of combustible tobacco can have a huge potential public health benefit. I'll say that again. Anything that reduces the use of combustible tobacco has enormous potential to improve human health. The real problem, though, is that we have uptake of nicotine addiction by entire generations of kids that would never have dreamt of using combustible tobacco. And the real balance here, and the real public health impact of these devices, is going to be which of these two will dominate the future. And I would be lying if I said I knew the answer to this, but I would also be lying if I said I'm not very, very concerned about the millions and millions of teenagers who are taking up vaping right now and what their future looks like from a health perspective. But if we could convert every single adult smoker in the US right now to electronic cigarettes, there is no question it would have a net benefit on public health. So I put this slide in here to show you one thing, and that the idea of an electronic cigarette is nothing new. The first patent for an electronic cigarette was actually filed in 1930. And here's a picture of the proposed device in that. And the first commercially successful electronic cigarette was actually developed by a pharmacist named Han Lick, who was a smoker. And he developed it because his father was dying of lung cancer at the time, and his father couldn't quit smoking. It was originally named as Ruyan, which is a Chinese word for like smoke. It was commercialized, and ultimately devices like this have been taken up, redesigned, and redeveloped in numerous different forms. So I put this term up here, the modern electronic cigarette, and the fact is that no modern electronic cigarettes look like this at all. It probably made sense for the first designers to make these look like cigarettes, but as people have probably figured out over time, more and more of these devices are coming out, and very few of them look like a fake cigarette. But they all have some elements in common. They have a microprocessor that precisely controls the temperature. They have a chamber that is heated with a very precisely controlled coil of some sort. There's a sensor that detects airflow, and it immediately releases that airflow into the chamber, which heats the electronic liquid, and whatever is in that liquid is rapidly inhaled into the lungs. And so, of course, most of these are designed to deliver nicotine, but you can deliver a lot of things through the lungs. And we'll talk a little bit about more of that. This is a product developed by another company, which I won't use their name because I don't want to give them any credit, but it is what's called a heat not burn device. It is sold under this, which stands for I Quit Ordinary Smoking. This is the name under which it is sold. And it uses tobacco that's very precisely processed. It heats the tobacco, not a liquid, and releases nicotine at a level that is close to, but doesn't quite recapitulate that of a combustible cigarette. And these are quite popular in Japan and are becoming increasingly popular in the US and Europe. But I have not seen a lot of these myself walking up and down the street. And I'm going to put the good in quotation marks because I'm not convinced there is any good to be had of these. But if there is a good, and I think this is a very important thing to acknowledge, if there is any good to be had from the development of these products, it rests in their potential to reduce the harm from combustible tobacco. And harken back to what I said earlier, that combustible tobacco is far and away our enemy. As public health officials, as pulmonary physicians, as healthcare providers of any sort. Combustible tobacco is our enemy. And adults who are addicted to nicotine have several FDA-proven, modestly successful options for tobacco cessation. And so, there is absolutely no evidence yet, and we can talk about some evidence that these electronic cigarettes actually promote cessation. I think they have potential in that regard, but just like a lot of things that have potential, that potential may never be realized. So we always recommend for adults trying to quit that they first use FDA-proven tobacco cessation pharmacotherapy, and I can't emphasize this enough. If you have an adult who's trying to quit smoking, this is always going to be your best first option. But it is true that there are adults who, in spite of using many of these different medications, cannot quit smoking. And they will often come to us or come to me in my clinic and say, sometimes very sheepishly, a patient may admit to me, doc, I've been using electronic cigarettes. And the first thing I do is I try to take them off their guard. I say, you know what? I would much rather have you do that than smoking combustible tobacco. It's the first thing is I want the patient to let down their guard a little bit. I always try to tell them that if they haven't, then they should try FDA-approved pharmacotherapy. But if someone has quit smoking and fully quit smoking with the use of an electronic cigarette, I will support their continued attempts at combustible tobacco cessation any way I can. We need to support smokers who are trying to quit because it is just so very profoundly addicting. Anything we can do to get adults off combustible tobacco, I think, is something I can support. So if, and I use the term if very strongly here, if there is a good, it rests in the potential of these products to reduce the harm from combustible tobacco. And what is the evidence that these actually help people quit? This is a paper that gets cited a lot. It was published last year in the New England Journal of Medicine. If you're interested in looking up the reference, it's right here. And the data really look like this. People were given either electronic cigarettes or another single nicotine replacement therapy and said, go quit smoking. They were also given extensive tobacco cessation counseling, and I have to emphasize that this was not just somebody who walked into a drugstore and bought an electronic cigarette. This clinical trial was done with people getting active, professionally delivered tobacco cessation counseling. And when they followed up with them at a year, there were far more people in the e-cigarette group, about double, than in the electronic and the non-e-cigarette group that were able to have quit smoking. The problem with that is that this is not real-world use of electronic cigarettes. Most people using these are not actively engaged in tobacco cessation programs. If they are, it's reasonable to expect that these might help. But this is not what real-world use of electronic cigarettes look like. And if you get on social media and look at electronic cigarette advocates out there, they are, I'm going to say it, somewhat crazy about defending their use of these, but very few of them are using them in fully professionally driven tobacco cessation programs. And if they are, perhaps they are being as successful. But these numbers are the best numbers we have from a not so well done clinical trial, which was published in the New England Journal of Medicine. This is the best data. There's plenty of other data out there, in fact, that says that these are not very effective cessation agents. And I will let ultimately everyone be the judge of the data that's been published, but I would encourage you to read primary peer-reviewed source data on the outcomes of people trying to quit smoking with these and recognize that there's a lot of flaws in just about every one of these studies. And we talked earlier about whether it is safer. There's no question when you compare the amount of nicotine and tobacco-derived carcinogen, and that's really what all these numbers show. All these big numbers are basically different tobacco-derived carcinogens, and the amount that you can find in combustible cigarettes versus electronic cigarettes. And if you want to compare these big numbers to these small numbers, well, what that really tells you is that from a carcinogenic standpoint, these are likely to be safer. That assumes that there's some threshold value below which these harmful chemicals don't have much harm. But if you really want to ask me which of these I would rather have, I'll take the ones up here that have virtually no detectable tobacco-derived carcinogens. If I'm trying to quit smoking, I want all those carcinogens out of my blood and I want them out of there quickly. So safer is not necessarily safe. If these were marketed today without any prior combustible tobacco on the market, and some pharmaceutical company came out and said, well, I have these things that have very low levels of carcinogens. Is there anybody who in their right mind would take up the use of electronic cigarettes? And I would argue that the answer is no. But I would also argue that the teenage uptake of these is an indicator that the teenage brain is different from the adult brain. And I say anybody in their right mind, most teenagers don't make long-term decisions about their health uh, using the kind of logic that an adult would use. And so I'm not sure teenagers aren't necessarily in their right minds. And I don't mean that in a bad way. I have two teenage sons myself, and I love them to death. But teenagers aren't known for making rational decisions. They text and drive, they drink and drive, they take risks that adults wouldn't take. And part of that is simply hardwired into the teenage developing brain. These are brains that have not fully developed, which is why it's that much more important to keep these addictive substances out of their hands. And so going back to the Surgeon General's report, which was literally just published a couple months ago, there are no major health organizations other than outside the United Kingdom that recommend electronic cigarettes as cessation aids, though some professional societies, including some that I am a member of, recognize the potential value of completely switching from combustible to electronically delivered nicotine. That is, what you don't want to do is see people engaging in what is referred to as dual use, that is, smoking combustible tobacco when they can and supplementing their nicotine addiction with electronic cigarettes. I think that is a very, very bad idea. And there's pretty good evidence that that is not safer than single use of combustible tobacco. But the Surgeon General's report goes to great lengths to emphasize the fact that all the public health agencies on the planet, all but one, recommend against using these as cessation aids. And then you get to the idea of where this really is going. And this is one of the first clues of this graph that shows basically market share of electronic cigarettes from 2011, when they really began to take off in 2013. And what has happened since about the last quarter of 2017 is a new enormous giant has emerged on the market. And that giant is sold under the name of Juul. And I typically try to stay clear of brand names, but I think in this case it's worth pointing out what happened with Juul towards the end of 2017 is began to take over market share, where towards the end of 2017 it was about 1/4 of the market. And as of about 6 months ago, Juul represented about 75% of the electronic cigarette market. Well, why is this such a big problem? Well, the people that are using it are our teenage sons and daughters. And that should scare everybody. And here's part of why. Here's the number of Juul-related posts on a social media platform. And you'll notice these dates down here at the bottom should look very familiar. These are the same point in time over which Juul began to essentially take over the entire market of electronic cigarettes. And I don't think there's any coincidence that they had a very, very powerful and very well-organized social media campaign. And if you're interested, just get on Instagram or Twitter and just type in Juul and see what you see. And it'll become obvious why this has become, I think, the next potential serious threat to public health from a nicotine and tobacco perspective. What happened over the last 3 or 4 years? Well, here's 12th graders and the prevalence of use of electronic cigarettes in the last 30 days in 2017, where it was 11%, and a year and a half later, it had more than doubled. This is now almost a year-old data. These are people who had ever used vape products. This is in the last 30 days. These are teenagers who ever admitted to their use, went from 25% up to 40%. These are your middle schoolers. These are your high schoolers. They're in your neighborhood. They're in my neighborhood. I see electronic cigarette refill tubes in the park near my house when I take my dog for a walk. And this is why, because these things are being heavily, heavily marketed to a population that is extraordinarily susceptible to the addictive potential of nicotine. And I think this should alarm all of us. And so I said I wasn't going to talk about brand names, but I think it's important to understand the other reason why this is so popular is that Juul does not use a liquid. Juul uses what's called a nicotine salt. and it results in a very, very rapid rush in the brain, much like freebase cocaine gets to the brain more rapidly and is more addicting. The same can be said of the form which nicotine takes in a Juul product. It is delivered much more rapidly to the brain and has much greater addictive potential. And here's a graphic depiction of how that compares from a Juul inhalation to a combustible tobacco inhalation versus other electronic nicotine delivery systems. This should be very, very frightening to anybody interested in protecting teenagers from this problem. And just another example of what happens if you look over time at the uptake of tobacco. And I'm not going to spend a lot of time on this slide other than to point out that this is a very interesting reference to look up on JAMA Network, the prevalence of electronic cigarette dependence amongst youths and its association with future use of combustible tobacco. Again, this should frighten everybody. The data are very, very concerning. And so that brings us to this issue of how these things are becoming harmful. And before we even get to this electronic valley associated, EVALI or electronic cigarette associated lung injury, even before that, if you really want to be horrified, just Google image search e-cigarette injury and look at some of the things that happens, because these are unregulated products with lithium ion batteries, and what could possibly go wrong with a lithium ion battery that's made by an unregulated manufacturer. Some of these things are terrible. This is someone who's losing a tooth. These are things that have exploded down here in the left. And so you'll see a lot of terrible, terrible things happening. And then, well, brings us to the real topic, which is this EVALI, electronic cigarette or vaping associated lung injury. I did not come up with that abbreviation. I probably would have come up with something that was a little easier to pronounce. But if you looked over the past 6 months at the CDC website before the coronavirus outbreak, the front page of the CDC was dominated by information on this EVALI epidemic. Data which stopped being recorded and updated daily as of February 18th, 2020, there were a total of 2,800 hospitalized individuals, 68 of whom had died. Rates at that time were falling sharply, and I think in large part because of recognition of the disease and the amount of attention this had been given. One of the things we were able to learn is that among those for whom information was available, use of THC-containing products was reported by 86 of those who had suffered EVALI. So what is THC? Well, that's the active ingredient in marijuana. And as I alluded to earlier, you can put anything you want in these liquids, and it's very effective at delivering to the lungs. And it turns out a lot of people were using, and therefore a lot of people were selling THC-containing liquids. And these were being sold by informal manufacturers off the street. And it probably is this source of the electronic vape liquids that was causing a lot of the trouble. Although 11% of those who were sick reported exclusively using nicotine-containing products. Generally, if you are older, you are at greater risk of dying. So those people who died were on average much older than those who survived. This website here is at the bottom of this page. And you used to be able to find this by simply just typing in cdc.gov. If you want to Google CDC and EVALI, it's still a very, very active web page, but of course it has been largely displaced by enormous concerns surrounding the coronavirus epidemic. But this information is still being maintained by the CDC at their website, and there's a lot of good information there, as well as links to other important resources to help us understand this. I put this picture in here because people want to know what the vaping lung injury looks like. Well, the truth is there's nothing specific about that. If we were to show this to a pathologist with no other information, all they would say is, yeah, this is some sort of acute injury to the lung epithelium. There's a lot of inflammation in here, and these cells down here have what are called lipid vacuoles in them. This is very common in smokers. But what you have here is something that looks like what pulmonologists call ARDS. And a lot of us are more aware of what ARDS is now because of the coronavirus epidemic. But this looks very much like ARDS, although it seems to be more centered around the airways, which makes sense because this is being delivered to the lungs through the airways. And what you have here is a lot of inflammation around the airway and essentially dead airway cells. This should be lined by a healthy looking epithelium. And what you have is cells that have been severely damaged by something that was inhaled. Well, We're getting better at understanding what has been causing all the trouble. There was a paper published describing 19 fatal cases for whom the data was available on substance use. The vast majority of them were inhaling substances containing these THC-containing liquids, so a marijuana active product. But a small proportion of them were using only nicotine. 4 of 19 were actually using dual products, but a very small proportion were still using just nicotine-containing products. So you can't necessarily blame the marijuana product for it. It's probably whatever those are being diluted in. And as it turns out, over time, these cases were being reported in all 50 states in varying amounts. Here we are in Michigan. We were somewhere in the middle, not as bad as it was in Illinois, New York, or Texas, or California. But we eventually were able to learn where these things were coming from. These are characteristics of cases presented in a New England Journal of Medicine paper, which was published very recently towards the end of 2019. And the most interesting thing to come out of this paper, in addition to the fact that the vast majority of patients were using, or vast majority of subjects were using THC-containing products, either with or without nicotine, they eventually were able to gather some of these products up and begin to analyze them for what they felt were kind of high priority toxicants, some sort of candidates they thought were there. And what they were able to find was that vitamin E acetate was in 48 of the 51 containers they were able to analyze. So a significant portion, 94% of them, had detectable vitamin E acetate. Now, vitamin E is a harmless dietary product that's in a lot of foods we eat, and it's in a lot of vitamins we take, but those are meant to be ingested into the stomach, where it's absorbed and properly incorporated into our body. You can't inhale heated vitamin E into your lung and expect things to go well. It will essentially dissolve your respiratory epithelium, as will any of these oils. If you inhale oil into your lung, it is not meant for that. And it turns out that it's bad enough that it can result in lung injury severe enough to lead to death. And we think that's the major problem. There's a lot of good circumstantial evidence that vitamin E acetate, VEA, is in fact the culprit here. So they were able to go back and look at e-liquids that were confiscated amongst various states and other municipalities where these things were being confiscated by police. And prior to 2018 or 2019, there were very few of these products where they found vitamin E acetate. And they really didn't start finding these things until early 2019, which really correlated to when this outbreak was first detected. In Minnesota, for example, all 10 of these products were seized by law enforcement. Prior to 2018, not a one of them had vitamin E acetate in it. 20 of 20 products seized during the September 2019 raid at the peak of the outbreak contained vitamin E acetate. It's almost as if a single source started producing these liquids with vitamin E acetate, which looks very similar to other types of oils. You can't tell from looking at it. And the quote from this paper was consistent with laboratory measures and trade websites. The addition of vitamin E to product fluid began to appear in the illicit market in late 2018 or early 2019 and gained popularity in 2019. It really is very good circumstantial evidence. It was ultimately recognized by the Surgeon General, and as part of their report, the latest national and state findings suggest e-cigarette or vaping products containing THC, particularly those obtained, and this is key, off the street or from other informal sources, are linked to most of the cases and play a major role in the outbreak. And I think this has to be emphasized. It's the people who are getting sick from this don't seem to be the ones that are walking into their local drugstores and buying, if you will, brand name e-cigarettes. And as much as I'm not a fan of e-cigarettes, I think these so-called brand manufacturers are not to blame for this. I think a lot of this is people getting it from their friend down the street, buying it off the internet from informal and less well quality controlled sources. They're probably the source of this. This is circumstantial evidence, but it really is quite strong in that regard. And I think those are probably the things that you need to be aware of if and when you see somebody in whom you suspect the possibility of electronic cigarette associated lung injury. If you're looking for case definitions for patients with EVALI, Nowadays, if you walk into an intensive care unit or an ICU or an emergency room with these signs and symptoms, the first thing we're going to think of is corona. But 8 or 12 weeks ago, if you walked in with these symptoms, we were very, very suspicious that this was related to vaping. And I don't think we should lose sight of this. I spent 2 weeks in our ICU recently taking care of people with acute lung injury. Many of them had this COVID-19 related lung illness, but in fact, we had one young woman who was still suffering from the effects of a long ICU stay being treated for vaping associated pulmonary injury. So this is probably still happening, but at a much, much lower rate than it was earlier. And that evidence is right here. We've all seen the phrase flatten the curve. Well, this is the curve, if you will, of e-cigarette associated lung injury, which peaked in September of last year and really seems to have fallen off our radar in the midst of this coronavirus epidemic. But as small as these bars are, they aren't zero yet. I don't know how much of this we should expect to see in the future. And hopefully we don't see some new epidemic of some new toxicant added to these informal e-liquids in the future. But hopefully we have seen, I would hope, the end of the vitamin E epidemic, if you will. We don't know for sure that's what this was, but I think the evidence is quite strong. But this is what we're looking at right now in terms of epidemiology. Uh, this this was published in January by the CDC because what they were seeing is that a lot of people were being sent home, and then people were being readmitted or dying, in fact, after discharge from initial hospitalization after treatment. This was a very small proportion of people, but they recommended particularly keep an eye on those with underlying pulmonary disease, cardiac or pulmonary disease, diabetes, and increasing age, and that if you were going to discharge folks treated with EVALI with these characteristics, make sure that you checked on them within 48 hours by telephone call or by a clinic visit face to face. This was evidence that the CDC was very, very concerned about a couple of months ago, and I think this remains relevant today. So, in summary, there has been a very, very widely publicized and widely discussed epidemic of e-cigarette and vaping associated lung injury, but it has to be viewed in the context of a much larger epidemic of nicotine addiction. I would emphasize that the availability of so-called clean nicotine delivery systems holds promise that is heretofore unfulfilled for adults who are addicted to nicotine, and that our real big concern in this context is teen uptake of vaping. And you have to be concerned about this because there's very limited evidence that suggests these things actually increase cessation rates for those using combustible tobacco. And that evidence that's out there, I think, is kind of flawed, even though it was published in reputable journals. There's been plenty of criticism of that journal article. We know that dual use is not healthier. It's just simply preserving the habit, and that unregulated e-liquids that have emerged in this upper context here have resulted in cases of fatal lung injury, which are really preventable and entirely preventable, in my opinion, and truly tragic. A lot of young people's lives were cut short. And with that, I'm going to defer back to our host.
Great. Thank you very much for your presentation, Dr. Ehrenberg. We really appreciate it. And now we'll hear from our next speaker. Rita Seith is originally from Pennsylvania and moved to Michigan to get her MPH from the University of Michigan. She now works at MDHHS as an opioid surveillance coordinator and is the lead epidemiologist for the EVALI outbreak. Rita, I'm going to turn it over to you.
Hi, everyone. It's a pleasure to be here, even though we're, doing it through non-traditional means. Fair warning, I have a puppy at home who does not like being closed out of my office. So if you hear some puppy noises, that's what it is. So I've got 10 minutes to just kind of quickly recap the EVALI outbreak, which I know right now seems like, decades in the past. But I'm just looking forward to recapping this for you. So the EVALI outbreak was e-cigarettes or vaping product use lung injury. And, we had just so many moving parts that needed to be coordinated. And as we're learning more as a country, the CDC is coming out with new tools, and then we are turning around to try to quickly coordinate with local health departments and our state lab. So, the CDC was providing states with case definition, data collection instruments for case interviews and medical record abstraction, which, I think that we went through like 4 different iterations of instrumentation and interviews. Each time, we need to quickly get that information out to local health departments and kind of onboard them to these new tools like within 24 hours. The CDC was receiving epi data from states, and they were reporting out weekly. We had local health departments, doing interviews and feeding that information up to us. We're coordinating with local health departments and the state lab on testing, because throughout this whole process, we're collecting products from all of the cases and sending those to the FDA lab for testing, which all, of course, have to be routed through our state lab. And then we were also collecting tissue samples and BAL samples for analysis and sending those to the CDC. Just for those who don't know, a BAL is a pretty invasive procedure where water is squirted into the lungs and then sucked back out, and they test that liquid, which, a couple really, really unique papers were published using the BAL testing results. Anyway, so I just wanted to put the slide in there to stress the immense collaboration that happened on such a quick basis. So as I started to just kind of touch on, this was the case definition that we finally settled on, coming from the CDC. So we were looking for cases that had used an e-cigarette for vaping, or they were like dabbing in 90 days prior to symptom onset. I got to tell you, we worked very closely with the tobacco section on all of the lingo and logistics. Because public health people, we were not well versed in just vaping products and terminology, and had to learn quite a bit. So dabbing is, instead of a liquid, they're inhaling something that's more of a wax that gets heated up. So history of vaping, and that we're seeing positive imaging. So pulmonary infiltrates, like opacities on a plain film chest radiograph, or ground glass opacities on a chest CT. And no evidence in the medical record of, alternative plausible diagnoses. So really that people are coming in with positive imaging, serious symptoms, and there's no other plausible cause. And then for a confirmed case, we're also looking for a number of negative infectious disease testing, including a respiratory viral panel. We're looking for an influenza PCR, and a number of other things listed here. So if not all of those tests were done, then they could be a probable case if the clinical team thought that vaping was likely the cause of these symptoms. So as I've mentioned, this really ramped up quickly. So here we see the investigation week number on the x-axis, and then the cumulative cases reported. So we went from, I mean, that first case rolled in on a Friday, of course, as they always do. And within weeks, we were just seeing doubling of cases. So now we are actually at, as of, I think late March, 132 cases reported. And, I think that other states saw it, like exactly this trajectory. So this breaks it up a little bit better. And again, for an outbreak that is non-communicable, it was just really amazing to see such a peak, right? So here we see the hospitalization months in blue, and then the symptom onset months in yellow. And let's see, I'm actually going to skip forward a little bit to show you the national numbers. It was just amazing to see a peak, because honestly, until this point, we didn't think that there was going to be a downturn. And we're thinking, as we're all very overworked, what are we going to be doing with this long term if this doesn't change? So I'll just move back here to show you the map by county of confirmed and probable EVALI cases in Michigan. And we can certainly see some clustering here, but largely in the more densely populated areas. And then looking at the national data, some counts that I'm sure you probably all have seen, but the last CDC update was late February, and we were looking at almost 3,000 hospitalized EVALI cases from 50 states, and 68 confirmed deaths in 29 states, plus the District of Columbia. So then here is the substances reported for Michigan cases on the left, and then a comparison between the Michigan cases and the national cases on your right. And it was just amazing to see the direction that it went, because again, initially we just didn't we just didn't really know what was going on. But you can see here that our counts largely resemble the national numbers, and that a large majority of the cases were using THC, followed by nicotine use, with a smattering of other things. And this information was based on interviews done with cases. So here are the demographics, age, and then gender breakdowns of Michigan cases, and then the US. Also pretty similar, mostly male and age 18 to 34. But we did see quite the range. A number of cases over the age of 50, and some really devastatingly young individuals as well, which I think also speaks to the severity of cases that we were seeing. So kind of starting to bring this together a little bit more, looking at the FDA testing done, the CDC testing done. This is really where things started to turn. We started to see trends with most products having THC, and then really seeing that vitamin E acetate as a diluent showing up in the BAL fluid, which again is that like liquid squirted into the lungs and sucked back out, and then also in the products sent to the FDA. So vitamin E acetate is something that someone could add to that liquid to kind of fill it out as a filler. So if you think about like food, like a good quality meal, would have really wholesome ingredients, and to like fill that meal out, and maybe cut costs, people might add some other things that aren't as good quality. And so anyway, so these results starting to come in are really why the CDC has stated that vitamin E acetate, in addition to some THC-containing e-cigarette or vaping products, is strongly linked to the EVALI outbreak. But evidence is not sufficient to rule out the contribution of other chemicals of concern. Especially there were some EVALI cases that we weren't able to link to vitamin E acetate. But the product testing was, we were collecting absolutely everything that cases had. And so there was just a lot of work that had to go into this. And it's still a little unclear why we saw such a peak and then a fall. But we are thinking that trade websites were suggesting that addition of vitamin E acetate was like being added to product fluid in the illicit market in early 2019. So largely, the recommendations are probably what a lot of people are going to tell you. Regardless of the investigation status, the whole time we were pushing that children, youth, pregnant women should absolutely not vape. Nobody should use street or modified products. And adults who do not use tobacco now should absolutely not start using e-cigarettes. We are still collecting cases, so see a provider if you have any symptoms, and also use e-cigarettes. And like for everyone, really be hesitant about or careful with where you get your products. And then I think a key element here is our collaboration with the Marijuana Regulatory Agency in Michigan, who now bans the use of vitamin E acetate and requires testing of THC vaping products for vitamin E acetate. They also have issued a number of recalls for some THC vaping medical marijuana products on the market because of these findings. And again, moving forward, we have a website that has some more information, and even though the CDC has discontinued data collection, they are supporting states as needed, and we continue to kind of have our feelers out for cases. So key messages here, one of which I think Karen will talk about, but just some free help in quitting smoking. Reminder that e-cigarettes are not FDA approved as a smoking cessation device, and to please feel free to reach out if you have any other questions. Here is my work cell and our shared vaping email address. And then Martha Stanbury, I worked quite a bit with, and she was the coordinator for our little team. Anyway, so I guess let Amy know if you have any questions, and I'd be happy to answer them through email or over the phone. Thank you.
Great. Thank you so much for the presentation. We really appreciate it, Rita.
Yeah, of course.
Our next speaker is Karen Brown, and she has been a public health consultant with the Michigan Department of Community Health in the Tobacco Control Program since 1999. Her primary responsibilities include serving as lead staff for consultation and technical assistance on implementation of tobacco dependence treatment services to local health departments, healthcare systems, and businesses throughout Michigan. Karen, I'm going to turn it over to you now.
Thank you. Hello, everyone. This presentation is going to give you tools to help reduce the risk of EVALI among youth by helping them to quit vaping. My Life, My Quit is a program that's been designed specifically for young people under 18. It launched in Michigan on July 1st of 2020, and Michigan is very proud to be one of the 17 states that are now offering My Life, My Quit to their residents. The hallmarks of the My Life, My Quit program really is teen input that was used to develop a program that appeals to youth while still following the U.S. PHS clinical practice guideline for treating tobacco use and dependence. As you can see, it offers multiple coaching formats to meet the varying preferences of youth when they're trying to quit. It helps with all tobacco, including e-cigarettes, and again, available to youth under the age of 18. Our My Life, My Quit program is staffed by coaches at National Jewish Health, located in Denver, Colorado. There are specially trained coaches that work exclusively with the youth. The National Jewish Health operates quit line programs in numerous states and has helped over 1 million people in their quit attempts. My Life, My Quit is funded for use in Michigan as part of the overall quit line program. And all coaches on this program have completed an accredited course in tobacco dependence treatment. There are multiple options to meet youth preferences. They are mostly interested, and this program is really built on the live texting portion of the program. There are other ways to get through, but the hallmark of this program is live texting, which feels a little bit like a chat and runs a little bit like a chat, but they're using their texting as most youth really do love to text back and forth. There are multiple ways that youth can enroll in the program. They can use the text option, they can call us, or they can enroll online. We make the enrollment as simple as possible and quick, again, to meet the needs of youth who are interested in going through pages and pages of enrollment information. It's most effective if we can get the youth to enroll. However, providers can encourage youth through this program and can enroll them through a online web referral. That web referral is protected, so you could be confident that your information isn't going to get out there and their information isn't going to get out there. There are additional text messages for ongoing support. And most importantly, it is free and it is confidential. So anybody who goes through My Life, My Quit doesn't have to go through any kind of a screening process. They will automatically be able to enroll without having to worry about income or anything like that. We get a lot of questions about nicotine replacement therapy, both from youth, parents, providers, whether or not we can do this. My Life, My Quit does not distribute nicotine replacement therapy. If you notice on the packages of all nicotine replacement therapy, it does say not for use for youth under the age of 18. That's just the way it's labeled by the FDA. So in order to legally purchase and use nicotine replacement therapy if you're under 18 is to get a prescription from your physician and have that filled. So our program is fairly new, but we are starting to see some success. The information you see here is looking at enrollments across the 17 partnering states for the last 6 months. Here in Michigan, in the month of March 2020, we have seen 7 enrollees. So we're not getting lots of enrollments, which isn't surprising considering that we are working with youth who may not be motivated yet to quit using tobacco or e-cigarettes. But as we continue to promote this with your help, with others' help, and with all of our advertising and advertising partnerships, we hope to continue to increase the number of people who enroll and hopefully to get them to quit. And lastly, our free marketing materials. Marketing is a huge factor in getting people to know that this resource exists, that it's free, that it's available to them whenever they need it. So we have a lot of free marketing materials that you can use. All of them can be downloaded at the link you see below for My Life Might Quit. We have pre-designed Facebook, Instagram, and Twitter messages and images. There are website banner ads. So if you have a website where you'd like to put up a banner ad on My Life Might Quit, those are available for you to use without permission. Just download them and use them. We also have some posters and brochures that you can print out on demand for your offices, meeting sites, things like that. We do have a few things for those posters and brochures. We have some limited quantities of that material, and those can be ordered from our email site, mdhhs/quitkit@michigan.gov. So that is all I have on My Life Might Quit. I'm always happy to answer questions. My contact information is actually at the front of this presentation. So I'm happy to help do presentations for you if you need that and supply any information you need about this program. I am also the contact for the Michigan Tobacco Quit Line. So if you have anybody who's 18 and over who would like to call the Quit Line or use any of the online services of the Quit Line, please let me know, and I'm happy to get you information about that as well. Thank you so much, everyone.
Great. Thank you so much for your presentation today, Karen. Thank you for joining the Michigan Cancer Consortium's webinar on electronic cigarette, vaping, and associated lung injury. Please visit the MCC website at www.michigancancer.org for associated resources with this webinar. Thank you.